for neurodegeneration of diagnose, predict, and monitor neurological disorders. He has been involved in the writing of 5 successful grant proposals funded by Qatar National Research Fund and Hamad Medical Corporation. He is the lead author of 13 papers and co-author in 75 papers. Today, he will be presenting diagnostic biomarkers for dementia research. Dr. Georgios, floor is yours. Thanks.
Thank you, Dr. Pritchard, for the kind introduction. It's a pleasure to be here to present to you about diagnostic biomarkers for dementia research. It has been an excellent and very informative conference. Thank you, Dr. Pritchard and Dr. Nali for organizing this. So, a quick overview. Let me see if I can. Yeah, a quick overview. I'm sorry, are you able to see the slides as I'm changing?
Yes.
Great, okay. A quick overview. I'm going to give a brief introduction about the utility of a biomarker in dementia. What are the current accepted biomarkers for Alzheimer's disease research, the limitations, and areas for improvement in biomarkers. And then I'm going to talk what's the evaluation plan to test the diagnostic efficacy of a biomarker. And with that, I'm going to use as an example our ongoing 8 years project that's conducted in Rumeila Hospital, led by Professor Reyes Malik from Weill Cornell as a lead PI, and by Dr. Hannadi as a PI from Hamad General Medical Corporation. And then I'm going to talk about what are the potential objectives that you can set for your projects, depending on the stage of the development of the biomarker, to validate the biomarker. Also equally important, how to set up your timeline and your milestones as you break down what you're going to deliver throughout your timeline. It's very important, especially when you have a funding and you need to show what you have delivered with your project. Other things I'm going to cover is recruitment strategies, very important, in order to ensure you get the numbers you need for your required sample size. I'm going to show you how a study procedure looks like. Facility is very important, and the personnel you choose for your study in order to get all the study procedures done. How inclusion-exclusion criteria look like, and then something very important to think about is the risk assessment and how you're going to mitigate or eliminate these obstacles. Sorry, I'm not going to cover anything about clinical trials. That has been very well covered in great depth by Dr. Chandra, and I'm not going to talk about data analysis dissemination. That's been covered by Dr. Pritchard. So, the utility of a biomarker for dementia. A biomarker can provide either direct or indirect evidence of the underlying pathology of the disease. It can predict disease progression by identifying those with mild cognitive impairment who will or won't progress to dementia. It could also, it doesn't need to do all of these things, but it could do some of these things. It can enhance clinical trial enrichment. So if you have say you want to test a drug, and you just recruit patients from the memory clinic, it might not be the best thing, although you increase the chance of detecting those who will progress dementia, and you would like to see how many of them will be prevented by the drug. It might be good to have a biomarker which will even more enhance your trial enrichment by finding those who are at high risk of developing dementia and see how many of them will be prevented by the drug. The biomarker can also monitor the disease progression and can also identify the benefit of a therapeutic intervention. So currently, just allow me, let me just close this down because I cannot see it. Okay. At the moment, since 2018, the NIA diagnostic criteria has shifted the diagnostic role of a biomarker from just confirming the pathology, the presence of pathology, Alzheimer's disease, to identifying the disease in its asymptomatic stages. They came up with these things called ATN classification system, where A stands for amyloid, T for tau, and N for neurodegeneration. Amyloid can be detected through using a PET scan or using cerebrospinal fluid sample. The same thing with the tau, you can do it with the cerebrospinal fluid. For neurodegeneration, we rely on the FDG PET, amyloid PET, and also on MRI brain structure to look for atrophy. But these things, the current accepted biomarkers, they have several number of limitations. For example, to detect amyloid with a PET scan, it is costly and it can be healthy. There's some health hazard issues because the patients are exposed to radioactivity. Also, with being amyloid positive, it doesn't mean that all of them, I mean, there are a lot of elderly subjects who won't have any cognitive impairment. And there's no correlation between amyloid deposition and cognitive decline, so you cannot monitor the progression of the disease. And the other thing is that there is variation in the protocols, and there's lack of standardization, and what are the cutoff points in order to say that somebody has now dementia. With cerebrospinal fluid, although it's very accurate in detecting change disease, it's invasive, it's painful, and you cannot routinely repeat the test, especially for clinical trials. And yes, there are, although it's a very accurate test, there are conflicting reports regarding on what is the exact concentration of amyloid in the cerebral fluid to accurately predict the development of the disease in patients with mild cognitive impairment. And finally, with structural MRI, although it's very good and it's the oldest biomarker there which been used for dementia research, it has very poor diagnostic accuracy to distinguish between those who have mild cognitive impairment from healthy controls or those who have early Alzheimer's disease from healthy controls. So areas for improvement. We still need accurate, reliable biomarkers that are non-invasive and rapid or inexpensive. Why? Because at the moment for research, where we're recruiting people with mild cognitive impairment, we don't want to have these long procedures of things. If anything that's rapid and it's non-invasive, it's much more easier for clinical trials. We also need biomarkers that are better identifying those who have mild cognitive impairment who will progress or will not progress to dementia, to monitor the disease progression, to identify the benefits of the therapeutic intervention, and like I mentioned earlier, to better at enhancing clinical trial enrichment so we can reduce this required sample size you need for the trial. So when in the process of evaluating the efficacy of the biomarker, there is a process for that. You start first with a pilot study where you only need a small sample size. You don't need to calculate the sample size. You just recruit around the number of 20 patients. And there you have healthy controls and the other extreme people with dementia. And you just want to see if your biomarker in question can find any significant difference between these two groups. If you succeed to find a significant difference there, then now you can proceed to a cross-section study where you can recruit a larger sample size. And here, while you look at the differences between healthy controls and dementia, you can adjust for any other confounding factors that may be associated with your biomarkers, such as duration of diabetes, duration of cognitive impairment, hypertension, for example, okay? And if you find that still, after you've adjusted for all the confounding factors that there is a significant association, then you can also look at whether your biomarker is significantly associated with the severity of this disease, like cognitive function or physical disability, functional disability. And then you can also now look at what is the diagnostic accuracy to distinguish these two groups with performing ROC curve analysis. Now, if you've reached that point now that you see with your cross-sectional study that your biomarker is strong enough to distinguish the disease from healthy controls, then you can now perform longitudinal studies for two things: to detect the predictive ability of your biomarker. So say at baseline, where you have detected something abnormal on your biomarker, can that predict in 2 years' time or 4 years' time that they will develop dementia in people with mild cognitive impairment? And the other thing you can do is also do a follow-up assessment with your biomarker and see whether there have been changes in your biomarker. And then if this change is associated with the progression of the disease, like cognitive function If there is, then that's a good sign that your biomarker can monitor the progression of the disease. Now, as I said earlier, I'm going to talk about how you evaluate the diagnostic efficacy of the biomarker, relying on our, giving as example, our ongoing 8-year project that's conducted in Rumeila Hospital, which has been awarded an NPRP grant of nearly $700,000, yeah. And we have involved, well, the sites that are involved in this project is Weill Cornell, Medicine, Rumeila Hospital, ITRI, and QBRI, and I'll explain why, what's the role of these facilities later on in the project. And there are 29 investigators with different expertise and background involved in this project. This is how a timeline of a longitudinal study looks like. So we started recruiting patients in 2016 over the duration of 4 years for baseline recruitment. And then we started already in 2018 to recruit patients a 2-year follow-up, and it was going to end in 2022. Again, 4 years duration. And finally, we've already started recruiting patients at the 4-year follow-up, which is going to run until 2024. And we have left 1 year at the end, enough to do any further analysis that needs to be done to publish our work. Now, let me give you a quick introduction. What is the biomarker we're testing in this 8-year project? This is the corneal confocal microscopy, or CCM in short. It's an ophthalmic, an eye test. It's a non-invasive test where we can look at the actual structure of the nerves. Previously, you will have to do a skin biopsy, but because the cornea is a transparent tissue, you can actually look at the structure of the nerve. So have a look how it looks like. You slightly touch the eyes. There's no discomfort there as you apply the anesthetic. And these are white lines you see on the video there. These are the actual nerve fibers, which we use a software to quantify the number of nerve fibers, the number of branches, and also the total length of the nerve fibers. And we use a software so there's no, in that to enable us to do objective quantification of the nerve morphology. So we started with a pilot study, which was, it ran for 4 months. And the first, it appeared to us that, yeah, we can actually see that there's a significant change in the nerve morphology. There's a reduction in the nerve fibers, there's a reduction in the branch density, and there's a reduction in the nerve fiber length, the total length that you can see in the image. Even though in patients with mild cognitive impairment. So we proceeded then, yeah. So this is how it looks like when we analyze the nerve fibers. The red lines are the main nerve fibers, and the green dots are how we quantify the branches. And the total length, take into account the length of the main fibers and the length of the branches together. And you can see here that when we recruited 36 health controls, 80 patients with mild cognitive impairment, and 66 patients with dementia. This is actually the cross-section study, it's not the pilot study anymore. And what we see is that there's a progressive decline in these 3 parameters from healthy controls to MCI dementia. So the next thing we look at is to do a cross-section study over 2 years' time. We already published this in the Annals of Clinical Translational Neurology journal, where we show, and sorry for the busy table, but I'm just going to briefly show you here just the corneal nerve morphology, where you can see there's a progressive reduction in these parameters. And this is the sample size we have recruited. We have excluded diabetes. And we also do later on, and as we look at the regression analysis to adjust for confounding factors to see whether actually these changes that we see in the CCM in the corneal nerve morphology are strongly associated with the disease. Now, in this dot plot graph, we see for the corneal fiber density, branch density, fiber length, a reduction from health controls to MCI and dementia. Yes, there is an overlap there, but interestingly, it'd be good to see what happened to those people here, whether they are at risk, high risk of developing dementia in the future. This is the regression analysis I mentioned earlier, where we tested whether any of these 3 parameters, fiber density, branch density, fiber length, are associated with, in this case, with cognitive function using the MoCA score. There's the p-value significant with the functional independence measure, and then also with mild cognitive impairment and dementia. But we didn't find any association with the duration of cognitive impairment. Next thing we wanted to test is what is the accuracy of the CCM measures for MCI and dementia, and how does it compare with MRI brain structure, currently accepted biomarker for dementia. Again, this is a work that was published at the Journal of Alzheimer's Disease in 2020. And we show that, again, sorry in advance for the busy table, but what we'd like to show here is that here you have the parameters for the CCM. In this column, we have the parameters of the healthy controls, patients with mild cognitive impairment, and patients with dementia. And what we see here is that there's a significant reduction in the CCM measures in patients with mild cognitive impairment and also with patients with dementia. But although there is a reduction in patients with dementia, it is not significant. Whereas with using a visual rating of the medial temporal atrophy, we see that we cannot detect a change between healthy controls and patients with mild cognitive impairment. Okay, this is the p-value, but patients with dementia were significantly lower. There was more atrophy compared to patients with mild cognitive impairment and healthy controls. And here with the RC curve, what we want to show is that area under the curve for mild cognitive impairment, you see the red line, the green line, the blue line is for the corneal nerve measures. And you can see that there is an accuracy in detecting, distinguishing healthy controls from mild cognitive impairment. But when you use the medial temporal lobe atrophy visual rating, there's no significant way of distinguishing healthy controls from MCI. However, when you look at for dementia patients only, you notice that the CCM measures were comparable accurately like the MTMA, medial temporal atrophy visual rating MRI. Now, one second, let me just move this thing down. Okay. Moving on to a longitudinal study, where we wanted to test what is the predictive capacity of corneal nerve measures to detect progression to dementia in patients with MCI. So basically here, you only need the data at baseline. You don't need to have the CCM data at follow-up. And you just need to know at follow-up whether the patients have progressed or not dementia. Clinical assessment, the diagnosis that the doctors have written down in the medical history of the patient. So the timeline of this study was 5 years, and we had so far recruited 130 patients, with MCI, for which 107 of them, a mean age of 68, completed both baseline and follow-up assessments. And the median follow-up was about 2.5 years, with a range of 1 to 4.5 years follow-up. Anybody less than a year follow-up less than a year, we excluded them, and there were 20 of them. And patients who haven't done follow-up, we excluded them. There were 3 of them. Now, from those who we included in the study, the 107, 33 of them developed dementia, and that equates to 31%. Okay, and just to show you what we've done is we divide these 2 groups, those who didn't progress and those who progressed to dementia, which is 33 of them, and we look at the baseline measures for, let's say, cognitive function, which is for MoCA, and we can see there was already significant reduction in those who progress at baseline in the cognitive function. Same thing, we notice a very significant reduction also with the corneal confocal microscopy measures. And we also notice that these are all different brain structures, like we have whole brain, we're talking about volume here, gray matter volume, ventricle, hippocampus, and so on. We see that with a lot of them, there was a significant already reduction at baseline in whole brain, gray matter, enlargement in the ventricles, reduction in the hippocampus. Okay, that's interesting. So next thing, just to give an idea how it looks like, this is how the brain structure look like. It's for those who progress to dementia and follow-up, where you can see there's a slight atrophy compared to those who didn't progress at baseline. And also when you look at the corneal nerve morphology, you see that there is some visible reduction in the nerve fiber density there in morphology. So we perform RSA curve analysis to see what is the diagnostic accuracy and what is the sensitivity specificity. This is the good thing about the RSA curve analysis. It gives you the cutoff point, like anything lower or equal to that is abnormal, and what is the sensitivity specificity in percentage for that particular biomarker. And you also have the area under the curve. Now, if you cannot prove that your biomarker might be a good screening test, you may want to weight your sensitivity more into high sensitivity at the expense of lower specificity rather than having 50-50. Or, I mean, you can use that thing to look at what's actually the optimum sensitivity specificity. Anyways, looking at our example here, we see that hypocampy had a very high area in the curve, 78%, and it says with the intracranial volume percentage, because we adjusted for the cranial size of the brain and not just the volume of the brain, we see that anything lower than 0.44% or equal to that has a high sensitivity, 86%, and a low and a moderate specificity. Same thing with the whole brain. But here, that's the interesting thing with our biomarker we're testing with the corneal nerve fiber density, fiber length, and branch density, it ranges from 71 to 74% the area under the curve. Again, I don't want to go into details, just want to show you how it looks like, how you examine a biomarker. And of course, you always come across, in this case, see all the brain structures that they cannot distinguish those who will progress or won't progress. Next thing, we want to adjust for any confounding factors that may have an association with our biomarker, and what we had to adjust for, for the dependent variable, which is those who progress or don't progress to dementia. So we adjusted for hypertension because it was strongly associated with progression of disease, triglycerides and high density lipoprotein. And after we've done that, we see that, and this is the way we express it, the adjusted odds ratio for fiber density was 9 times more to develop, for those who had abnormal fiber density, to develop dementia. With abnormal branch density, the adjusted odds ratio was 11 times higher for those who, the risk to develop dementia. And same thing you can see with the hypocampal whole brain and the other measures we included from the study. So now I'm moving on to what are the recruitment strategies. See, we could recruit patients in neuroscience, in neurology, but we chose the memory clinic in Rumeila Hospital because we get there specifically patients who have memory complaints, and that will increase our chances of getting the numbers we require for our study. Like we have got an IRB approval to recruit 200 patients with micro impairment and 100 patients with dementia. That's a large number. Now, if you rely on recruiting patients in neuroscience, which you could do that, but they also recruit patients with other neurological disorders. So you might not get that frequently, as frequent as you could get patients to recruit from the memory clinic. Also, in the recruitment process, it involves looking at the eligibility of the subjects, like doing a screening and see if they're eligible for the study, and consenting them. Now, that's something that Dr. Bridges has already covered in terms of defining the sample size. But yes, you need to do a sample size calculation if you do a longitudinal study in order to take in consideration attribute for people who might drop out or might not be eligible later on in your study. And that's why your numbers increase. And then you take into account how strong, what's the effect size of your biomarker to detect changes. So if it's small, then you need a larger sample size. And you come up with these numbers. And for the study, like I say, we have visits at baseline, 2-year follow-up, 4-year follow-up. Now, study procedures look something like this, where you have the demographic, you collect data like metabolic measures, medications, and then the assessments you perform for this study is cognitive function, functional independence screening, to look for to rate for the severity of the symptoms of dementia. We use the clinical dementia rating. Also, for the diagnosis of MCI and dementia health controls, we use the ICD-10 criteria. We perform the corneal confocal microscopy, the device we have it in Rumeila Hospital for patients' convenience, not having to go, let's say, to neuroscience where we had the device there before. And also the MRI unit for brain MRI in Rumeila Hospital. And FDG PET is something new that we're going to start also in Rumeila Hospital. Now, for this study, we're also taking blood samples for research purposes and not for clinical purposes to look specifically for concentration of plasma beta amyloid, neurofilament light, and alpha-synuclein, which are biomarkers for neurodegeneration. Are we doing proteomic analysis, metabolomic analysis? These are things that are done in QBRI. Now, it's very important to select the facilities that you're going to have in your study. For example, while in Rumeila we do all the assessments like CCM, MRI, cognitive assessment, diagnosis, and so on, we collect the bloods. QBRI does the blood analysis. However, it's quite far from Rumeila Hospital. And for the process, for the analysis of the bloods, you need within half an hour when you extract the bloods to process them before you do the analysis. Now, you only got a window of half an hour, so we don't have enough time to take the bloods from Rumeila to QBRI. So what we've done, we collaborate with ITRI, which is very close to Rumeila, and allows us time to take the bloods there for them to process it, and another day to take the bloods, the processed bloods, to QBRI for the analysis. Just to show some distinguished investigators, the principal investigators involved in the study, and the key investigators who play a big role in coordinating the study. And then choosing the personnel for your study is very important. Because, for example, overlooking the project and acquiring funding always is the PI. But then again, when it's about screening and recruitment, you need the help of the doctors, the physicians, the nurses, and the coordinator. For diagnosis, you need to state, especially when you have a grant application or for an IRB submission, you have to say that you have the required personnel for these geriatricians and neurologists, in this case for our study. For CCM assessment, we have the experts from Weill Cornell, like my colleague, like Professor Yanis, Dr. Nan, who does the eye test, and myself. For MRI assessments, we have Dr. Elsa Tuhi and Dr. Sujit, neuroradiologists, to evaluate the MRI scans. And for cognitive assessments, we have dedicated staff for that, occupational therapists to look for this. And for blood processing, we have staff in ITRI and QBRI. So that's something you have to plan it in advance to ensure that you can deliver your project. It's really important. And when it comes to recruiting patients, very important to take into consideration all the inclusion and exclusion criteria, something that when you publish a paper, reviewers will always look at these things to make sure that your study has been planned, designed, it's valid, the design of your study. In our case, our inclusion criteria was patients, healthy controls, patients with mild cognitive impairment, and patients with dementia, that we included not only pure Alzheimer's disease, because we know from in our population in Rumeila Hospital, not all of them have, in fact, it's not the majority, but the majority is the ones who have mixed Alzheimer's disease and vascular lesions. So we included those, and also people with vascular dementia. Age, all of them between 60 to 85, age match for all three groups. And for exclusion criteria, we take into account all the neurodegenerative neurological disorders. Because we're doing the eye test, we take into account people who may have LASIK or anything that may affect the nerves, cataract surgery, that we exclude them. People who have severe dry eyes that may affect the nerves, also we exclude them. And any other possible things like peripheral neuropathies, because we know with CCM, we can detect peripheral neuropathies. So we exclude them to, apart from diabetes, because diabetes is highly prevalent, especially those who have vascular lesions. So we take into account these, we include them, but we adjust them when we do regression analysis. Now, like I mentioned earlier, before you start your project, it's always good to do a risk assessment, see what are the things that could go wrong, what are the potential obstacles, and how would you overcome, how would you mitigate these obstacles. So, for example, for the risk of recruitment delays, like we had the lockdown, right? And we couldn't recruit any patients for 8 months and so on. How do we overcome this? Well, we have enough doctors who will recruit the patients. We have also this other thing where we have people from all the primary health cares that refer the patients who have mild cognitive impairment to Rumeila Hospital and the Memory Clinic. So that increases the chances for us to recruit patients to compensate for any delays. Also, risk assessment of taking MRI. People may suffer from claustrophobia. What happened in that case if they have metallic implants? Do we exclude them from the study? No, we're not going to exclude them. We're just going to let them do all the other assessments without the MRI. And with FDG PET, if we didn't get enough numbers we need, because not all of them would do FDG PET, as we're doing it as a clinical assessment, not as a research assessment. So only those we cannot be sure whether they have dementia or MCI, and we need some PET assessment, and we do FDG PET on them. Maybe the numbers may not be high enough. So what we can do, we can extend the study possibly. We can extend the period of recruitment. So this is our potential solution to overcome these obstacles. So that leaves us with the last thing. This is, I hope you took from this something on how we can do research and developing a biomarker or validating biomarker for throughout the different states. You understood the process. I just want to give an idea from this big project. That was not the only thing that came out from just validating the biomarker, although that's the most important thing to look at, this diagnostic and prognostic accuracy of the CCM. We had the chance to establish clinical translation research across different institutions in Qatar. We engaged with the general public, with students from Weill Cornell in the final year. They did a project, which is like 4 months. We increased the awareness of dementia research and translation research. And our study, it fell aligned with the Qatar National Dementia Plan. Out of the 7 action areas, 4 of them, which is dementia diagnosis, treatment and care support, dementia risk reduction, dementia as a public health priority, and dementia awareness and friendliness. And yes, we won an award as the HMC Stars of Excellence for Research in 2017. With that, I'd like to say thank you very much for your attention. Our colleagues involved in the study, Dr. Nadi, who is helping very much for running this project, and Professor Malik, who started with the idea and found funding for the project. Thank you. Happy